triglycerides tend to go up with insulin resistance. And, we see uncontrolled diabetics sometimes with triglycerides hundreds and hundreds, maybe thousands high. Not a good situation. So as your triglycerides go up, especially if it's in conjunction with, if you get your hemoglobin A1C measured as well, and that starts to go up, that's a sign that you're metabolically not as healthy as you should be.
Welcome to Do You Agray, a space where we have real conversations. I'm your host, Bassam, and I have with me Jarmeen. And today we have a special guest, Dr. Jeffrey Brand. Welcome, Doc.
Thank you.
Welcome.
Glad to be here.
Thanks so much. Dr. Brand has been a friend, and we play soccer together, actually, which has been great. And he is a cardiologist, but maybe I can introduce you a little bit and your background. You were born in Colorado,
Correct.
Raised in Massachusetts, and you attended high school there up to college, where you went to Atlanta Union College, and where you received your BS degree in chemistry?
Biochemistry.
Nice. And then you moved to Riverside?
I did. I went to UC Riverside for a couple years. I was in their graduate chemistry program. I thought I was going to wind up being a chemistry professor. But about a year and a half in, I just felt like I'd sort of missed my calling. And my then girlfriend actually helped me apply and for the MCAT, and I went up to Loma Linda and just asked them for just walked in and asked for an application, wound up getting in, and then after obtaining my master's in chemistry, I switched and went to medical school at Loma Linda.
Nice. Awesome.
Graduated there in 1999.
Cool. Wow. So, also a graduate of Loma Linda. I loved my time there as well. And then you went into residency of internal medicine?
Correct. Harbor-UCLA Medical Center in Torrance. I did 3 years internal medicine residency, then did a chief resident year, and then worked as an internal medicine hospitalist for Kaiser Permanente for 3 years, seeing only hospitalized patients, nothing clinic-based. Felt like I kind of wanted to do something more, and the cardiology problems that I handed off to consultants seemed to be interesting ones. So I applied to Loma Linda. Unlike most of the other people I interviewed with, I only applied to one program because I felt like I had a connection to Loma Linda. It's also because my wife was already teaching chemistry here at La Sierra, and we were not going to move. And this was the only one in Southern California within driving distance. But been an alumnus and having some connections, some Adventist connections in particular, it helped. So I got into Loma Linda and started my fellowship in 2006.
How long is fellowship?
3 years.
3 years
for general cardiology. So 3 years general cardiology. I actually stayed at Loma Linda for 2 years after that, and then came back to Kaiser, and I've been with Kaiser since 2011.
Wow. So it's I think it's an amazing combination, like amazing background that, in your journey leading you up to cardiology field. You understand things on the molecular level as far as chemistry, and also you've seen real patients,
right,
and their general health and their struggles and lifestyle and all these things, and then finally cardiology, which is you're the superhero because it's the number one cause of death in the world and the United States.
That's one of the reasons I picked the fellowship. I tell people there's a lot of money in it, and they think immediately of salary, but there's a lot of money in research and development, and there are always new advances coming out. And patients tend to listen to you because everybody's worried about their heart.
That's right.
So
once your heart stops.
You wanted to be a chemistry teacher, but you married a chemistry teacher.
That's right. I married a chemistry professor instead.
And you taught for a little bit?
I did teaching assistantships. That's how you would sort of work your way through graduate school. So I
Mhm.
taught labs every quarter I was in graduate school. But beyond that, the only thing I've really taught is Sabbath school, I guess, at the La Sierra University Church.
Nice. Yeah. So that's interesting how you found that cardiology is I think is a there is a need, and so you went that route. And have you found solutions that you didn't know before as an internal medicine physician?
Judging by what patients actually wind up doing,
Mm.
sometimes I feel like Sisyphus, just pushing that giant rock up the hill, and it keeps rolling back down.
Mm-hmm.
But every once in a while, I get a patient who just completely buys in and does everything I asked of them, and they have a great outcome for it, and it's
That's
very
awesome.
rewarding.
Yes.
You know? And I talk with my
Yeah.
wife, and she teaches organic chemistry, and a lot of students see organic chemistry, OChem, as just a hurdle that they have to get over
Yeah.
on their way to something else. But every quarter, she has one or two kids that realize they like organic chemistry for organic chemistry, and she can live off that for an entire year, just one or two.
Yeah.
Not too many.
Yeah.
I have a funny story to share. So Dr. Machitlo, your wife, was my professor for I think just a few weeks, and then she went on maternity leave, and she's I think she's known to be tough.
Yes.
And so I struggled in the beginning, and then the substitute professor, I did very well and survived. But she went on maternity leave with your second daughter,
Uh-huh.
who happens to play soccer with us today.
Right.
Yeah, for pickup soccer. I thought it was hilarious. How time flies.
Yeah.
And the connections you build, and now we're here,
Right.
discussing heart health. But I wanted to get into your faith belief. And you mentioned your teacher, Sabbath school teacher. You're a Seventh-day Adventist, correct?
Yes.
Yeah. And so, how much of your faith influenced you to get into this field? And have you found connection between the teachings, of Seventh-day Adventist Church, who are known to be the longest living population in the world, I think.
Right. Well, Loma Linda is one of the blue zones.
Yeah.
Where you have a very high concentration, or an abnormally high concentration, of centenarians reaching over 100 years old. I'm not sure how much my faith played into it. Growing up in Massachusetts and New England, very conservative Seventh-day Adventism, it wasn't being a doctor. I was going into the medical ministry. That's what it would always be called.
Yes. Medical evangelism.
Yeah. I don't know. I just felt like that's what I was supposed to do. Whether that was some type of divine epiphany or just, I don't know, that's what I was good at, and that's what I was interested. I have, over the last couple of years in particular, thought about the things that I tell patients and realized that I think my better advice, actually, without saying it overtly in the office, has a biblical basis. And
can you give us an example?
Sure. The biblical account of the Garden of Eden, when this world was perfect, that's what I sort of aim for. The Genesis account says that God told Adam and Eve they had every fruit and vegetable and herb in the garden at their disposal to eat. They weren't just sitting there and having fruit drop into their lap. He also told them, this is your garden, you need to dress it and keep it. And so people need to be physically active and have purpose. If a person were to read Dan Buettner's book about the Blue Zones or watch the Netflix documentaries, that's one of the overlapping parts of the Venn diagram of the pockets around the world that are these blue zones.
Mhm.
Sardinia, the Nicoya Peninsula, Okinawa, Loma Linda. These people have community, they have purpose, they stay active and engaged their entire lives. They don't retire at 65 and then, I mean, you do, and you can shrivel up and die, or you can stay active, giving back and working and exercising and being active. And so the way it comes out in the office, and my daughters make fun of me like, Dad, we could do your job without going through all the school, is I tell people routinely the two things you can never do too much of, in my opinion, are eat vegetables and walk. And the only thing better than walking is walking uphill. And that's the baseline. And I 100% believe in pharmaceuticals and procedures, et cetera, and they have their purpose in testing. But if people were just to eat vegetables and walk, they would improve their quality of life almost immeasurably. And it's that, one or two patients along the way that really buy in and do that, and you can see them change, and keeps me going because I know it's the right thing to do.
Yeah. So what do most patients come complaining from?
Everybody in the office tells me they're tired. Everybody says, I'm fatigued, I'm tired. I don't have energy. And someone comes in and they're 88 and they tell you that.
Yeah.
You have to gently find a way to break it to them. You're 88, you're not 28. You're supposed to feel tired. If you want to take a nap in the middle of the day, do it. But when someone's 48 and, they tell you that they used to play basketball or football in high school, or a woman used to run track or something like that, but now it's 30 years after that, and it's 60 or 80 or 100 pounds more. And it's the stresses of modern life and lack of time and long commutes, and bad food is easy to buy, and it's cheap and it's quick. And how do you break people out of those patterns, the ruts that they're in? That's really difficult. I tell them fatigue there's many pieces to that pie. These patients will have sleep apnea. They get poor quality sleep. They don't have enough sleep. There's modern conveniences like our phones and the blue screen. There's plenty of research out there showing that, it disrupts your sleep pattern and you don't get good quality sleep. They're not exercising. So everybody comes and tells me they're tired. Then beyond that, the actual cardiac problems, a lot of people with coronary artery disease, cholesterol buildup inside the wall of their arteries. A lot of them, most of the ones I see, they've already had a heart attack. I either saw them in the hospital or they were seen somewhere else and referred to me. And so we have to manage their coronary artery disease and try and reduce their risk as much as possible of a future heart attack. I see a lot of congestive heart failure, both systolic, meaning that the heart is dilated and weak and cannot pump very strongly. But I see a lot of diastolic heart failure where the pumping function is fine, but the relaxing and filling is very impaired, which happens to all of us as we get older. Everybody's hearts get stiffer. If you live long enough, you will develop diastolic dysfunction. Our hearts, when we're young, suck the blood back in. When we're old, we get more and more reliant on a higher pressure to fill that stiffened heart pumping chamber. And people notice what the American Heart Association terms, they come with this term, effort intolerance. It's harder to go upstairs, even harder if you're trying to carry groceries. People try and exercise and they get winded easily. So I see a lot of people with heart failure. And then quite a few people with abnormal heart rhythms. Number one is atrial fibrillation. That's in the popular media because drug companies that sell blood thinning medications that you don't have to get blood work monitoring. We used to have only warfarin, brand name Coumadin, and now there's some brand name medications out there to reduce stroke risk. Kareem Abdul-Jabbar advertises for one of them. But I do see a lot of atrial fibrillation that's age related. We have an aging population, and maybe 20% of people that are 80 years old will have atrial fibrillation, and it starts earlier than that. So I see a lot of atrial fibrillation. And that's probably most of my days.
Mm.
Yeah.
What are some blood work markers you look at when someone comes to your office just to see where they're at
So I do get
with the
those
heart?
consults as well. I remember one consult I got, one of the first patients I saw after I'd finished my fellowship at Loma Linda came to my office and said, I'm the oldest living male relative in my family
Hmm.
who's never had a heart attack.
Wow.
How old was he?
63,
Oh,
65
wow.
or something like that. Like he had father, uncles, brothers, etc.
Hmm.
I get other people that are just sort of worried about it. So the most basic test, I guess, would be a standard lipid profile,
Okay.
which usually consists of 4 measurements: total cholesterol,
Mhm.
high density lipoproteins, HDL, the so-called good cholesterol,
Mhm.
low density lipoproteins, LDL, the bad cholesterol, and then triglycerides. And it's either calculated for you, or you can calculate also a 5th parameter, the ratio of total cholesterol to good cholesterol, or HDL, your total to HDL ratio. That's the first step, always, to see where you're at.
And where do you like to see the numbers?
So there are norms, normal ranges established through research promulgated by the American Heart Association. Total cholesterol less than 200. HDL for a man, we wanted above 40. For women, probably wanted above 45. LDL is a little bit of a moving target based on someone's history and risk. Like if you've had a heart attack, needed to get an angioplasty, well, we want to get your LDL below 70. We want to drive it down as low as we can. If someone is young and doesn't have any other medical issues like high blood pressure, diabetes, no strong family history, and they come in with an LDL of 120, that's not necessarily a bad thing. Over 130, then we start to talk to them about lifestyle recommendations. If it's over 160, lifestyle recommendations plus strongly consider medical therapy. Having read the book Outlive by Peter Attia, who was initially trained as a cancer surgeon, gave that up, and now does a lifestyle longevity clinic out of Austin, Texas. Excellent book. Highly recommend it. Don't mind saying that one out loud. I'm not going to shill for the blood thinner companies, but the book Outlive by Peter Attia I found to be excellent. He advocates for people that are really interested in assessing their cardiovascular risk. There are some other blood tests you can ask for or look for.
More than the lipid?
More than the lipid profile, and that would be lipoprotein A, or LP little a, sometimes people call it, which that's a little tough because if it's elevated and you have the genetic alleles that give you a high LP little a, there's really not a lot you can do about it because you can't pick your parents. Maybe there's a little medical therapy that can reduce your risk if you do have it. But it's good to know that, hey, okay, I can't change that, but I can change a lot of other things in my lifestyle. And then we also look at apoprotein B, ApoB, which may be a better predictor of cardiovascular event risk than anything we get out of the standard lipid profile. But the standard lipid profile is what I start with first. So total cholesterol less than 200, HDL 40 for a man, 45 for a woman. LDL is a little bit of a moving target depending on whether or not you have established coronary artery disease. Then triglycerides less than 150. And then the HDL total cholesterol ratio, we want to see less than 4 or less. Lower the better. I think that's one of the best markers you can have out of your lipid profile is your total HDL ratio.
So we'll get back to cholesterol in a little bit, but I was reading at the CDC, risk factors and things like that, and also it mentioned that ischemic heart disease is the number one killer.
Correct.
Is that the same thing as a heart attack?
It is. So ischemia is the general term in medicine for lack of blood supply. And so if you get a coronary artery that has enough cholesterol plaque buildup embedded in its wall that it narrows the luminal area,
Mm-hmm.
you can get to some exertion level where the demand for blood and oxygen supply from the heart muscle exceeds the supply that can get through it. And that's when people have what's called stable angina. They get some type of chest discomfort with some level of exertion relieved with rest or nitroglycerin. I see less of that and more, so that's stable disease. I see a lot more unstable disease. And that's when someone comes in and suddenly has the onset of some type of chest discomfort. They go into the emergency department or call 911. Eventually, blood tests show an elevation of a protein called troponin. Maybe there's EKG changes, and you put it all together, and they've had that cholesterol plaque, which before may not have been obstructive and never caused any symptoms, rupture or ulcerate open. The platelets in the blood will now stick to the exposed cholesterol plaque. Because again, before it's all embedded in the wall and the blood's just flowing freely. But if you expose that thrombogenic plaque to the bloodstream, platelets stick to it. The platelets activate more platelets in a cascade, and you can go from partially narrowed to very tightly, acutely narrowed the symptoms. And if that protein troponin has a rise and fall, then you've killed off some heart muscle cells and actually had a heart attack. So I see that acutely in the hospital and then managing that long-term, longitudinally afterwards, more often than people who slowly get narrowings and get stable angina. Just the way it plays out. I mean, I have stable angina patients, but it's with the advances we have in angioplasty, stent procedures, and the medicines we have, we do pretty well at relieving people's angina pain. But a lot of people still have heart attacks, still the number one killer.
What's the first thing to look out for? So let's say, is it the chest pain? And what should you do if that happens?
So
for a heart attack.
For a heart attack,
yeah.
Right. So when I talk with my patients, the chances I do get a chance to sometimes teach family medicine residents to rotate through cardiology, I say our first mistake is we say pain, because I have a lot of patients that don't have pain. So I tell patients and I tell residents that I teach, essentially belly button to chin all the way down either arm and say discomfort. Because people will have, sometimes it's just a feeling of uneasiness, sometimes it's a little squeezing, but it's not painful to them. They sort of want to please us by giving the right answer. Is it pain? No, it's not really pain. No, I don't have any chest pain. Well, do you have tightness? Oh yeah, I got tightness. And it's going here. So belly button to chin, all the way down either arm. Angina can show up anywhere. If it's a stable outpatient pattern, people will notice it with a certain amount of exertion that goes away with rest. They should obviously see their primary care physician, probably get stress testing to formally diagnose it, and then see a cardiologist and get any risk factors assessed. Since the late 70s, early 80s, when the emergency medical services 911 really started to get going, and actually the very first place they had that was at, I didn't know before I started there, but Harbor-UCLA Medical Center was like the first place they had 911 and paramedics, etc.
Wow.
In the nation. This guy, John Michael Criley was the cardiologist that started that. There's a lot of people that come in with some type of symptoms that wind up being fine.
Yeah.
But we have to have lots of
testing,
lots of negative, which in medical terms is good. We have to have a lot of negative testing and negative workups to capture as many people that are positive and actually have an event. So if people have the sudden onset of any type of chest discomfort in that same distribution, that's just out of character, they haven't had it before, they should use emergency, call 911 or go to an ER. I see it's almost always men, occasionally a stubborn old woman, but it's always these guys. Well, I thought it was heartburn. I thought it'd go away. And it kind of kept going, and they'll be with their wife or their sister or something, and the woman will just be shaking her head like this with her eyes closed. It's like, what took you so long? And they'll just shake even harder. Like, what finally convinced you to come in? It's like, well, it wouldn't go away, and she made me come in. So people delay. people should use the ER and emergency medical services. That's the way. That's one of the major ways we've reduced cardiovascular mortality since the late 70s, early 80s when that was implemented. There's better medications, much better procedures. There's a lot of protocols.
Chest pain, though, could be some gases or something.
It certainly can be, and one has to sort of, I guess, be cognizant of their own sort of risk profile.
So what makes someone more at risk for heart attack than other people? Is it like genetic, or is it lifestyle, what you eat, what you do?
That is a very complex question. A very complex answer. They're the classic Framingham risk factors. So there's a study, the Harvard School of Public Health followed these people in Framingham, Massachusetts, not far from where I grew up, longitudinally for like 30 years or something like that. And they came up with the classic ones: family history. So there's certainly a genetic component. And a family history of coronary artery disease is not grandpa had a bypass when he was 77. It's a first degree family member before the age of 50, 55 with a heart attack. So someone really early. So you have strong family history, smoking, diabetes, high blood pressure, and hyperlipidemia. So those are all risk factors, but there are people with beautiful cholesterol profiles that still have heart attacks, plenty of people that are not diabetics that have heart attacks, etc. So those are the classic risk factors that we sort of assess when someone comes in. And then it's the setting in which it happened, sort of the nature of how they describe it. And so, that's sort of the art of medicine.
Can you say them again? Diabetes?
So family history, first degree relative early on, 50s or earlier with heart attack, smoking, diabetes, high blood pressure, and high cholesterol, hyperlipidemia. So those are the classic risk factors. Now, we can't stop the clock. We can't pick our parents. I tell my patients that smoke, if you quit smoking, you'll more than double anything I can possibly do for you with medications. The blood pressure, the diabetes, the cholesterol, those are all modifiable risk factors. Those are aside from quitting smoking, those are the most modifiable risk factors we have. And in Peter Tia's book, Outlive, he talks about these things, and then lumps them together under metabolic health. Are people metabolically healthy or not? So someone can be on the younger side, still play sports, be reasonably trim appearing. But if they have the genetics for insulin resistance, which can lead to high blood pressure, and if your sugars are higher, then your triglycerides go up and your lipid profile's off, and people can look to be okay, but can be metabolically unhealthy. Now, there's plenty of people that look metabolically unhealthy, and they are.
They're okay.
No, they're metabolically unhealthy. Every once in a while, you get people, they can be very obese and inactive and have a good diet, and for whatever reason, they're blessed somehow genetically that they don't have insulin resistance in their A1C, hemoglobin A1C.
But then it catches up, I feel.
Yeah, eventually. What's their quality of life? Everything's better if you exercise and you're more active, etc. But I try and get patients now, when I look at their lipid profile, even as a cardiologist, I will look at their hemoglobin A1C, if they're diabetic or if they're pre-diabetic. I look at their weight, they're being right. And so I try and influence them to make lifestyle changes that will make them more metabolically healthy. I don't even focus on, I don't tell patients a weight loss number. We also go by body mass index. I don't tell patients they need to achieve a certain body mass index. I really try and get people now, I've sort of changed the way I approach it. I really try to get them to make good choices day by day,
Mhm.
almost like being in recovery
Mhm.
for drug and alcohol addiction. You know, the 12-step program, if you listen to the steps, it's really good advice. And, you know, take it one day at a time, one decision at a time. Try and be good 80%, 85% of the time with your, you know, because not everybody can make the perfect diet decision every time, I think.
Mhm.
But just make choices in your lifestyle. Choose to walk. Choose to eat a smaller amount at a meal. Choose to take the time to go to the produce section and purchase vegetables and find a way to cook them that's delicious but healthy. Make those choices every day. Make good choices every day, and then you'll have a good outcome. Don't worry so much about, because everybody wants, oh, if I was just 40 pounds lighter, if I could get that. Don't worry about that. Just start making good choices. Get metabolically healthy,
Yeah.
and that's how you lower your risk.
Yeah, I don't think it's the weight as much as making the right choices, because you can be so skinny and unhealthy.
It's true.
You know, some people just burn the
Yeah.
food fast.
Yeah.
So there's a lot of talk on mainstream about how animal-based cholesterol is actually not bad for you. It's actually good. You should have, your body needs cholesterol, but just make the right choices, whether it's grass-fed meat or wild-caught fish, or, you know, pasture-raised eggs. What would what's your stance on that as far as heart health?
So your body needs a lot of cholesterol. That's in every cell membrane that we have.
Mm-hmm.
Our liver makes far more cholesterol than we ingest. Even if you had bacon and eggs 3 meals a day, your liver would still make more. A lot of the issue comes is, how does it get packaged? How is it transported? Are you metabolically unhealthy with some underlying degree of inflammation where the cholesterol winds up getting deposited in your coronary arteries or not? So I certainly don't think that people need to go out of their way to eat animal-based proteins to get cholesterol. Your liver will make it. Vegans can synthesize all the cholesterol they need. Um, so I don't think people need to go out of the way to eat animal-based products just to get cholesterol. Your liver will make it.
What about for those who actually eat animal-based cholesterol, like the cholesterol from
I
animals?
think you're talking about going into ketosis. So a lot
Or
of the
keto,
people
or
that eat, you know, meat.
So I like Peter Tia's approach in his book Outlive, because he comes to diet and he's very upfront and just says, I don't know. And his thought is, you can do more harm with a bad diet than you probably can do good with some type of good diet. And then what is the good diet? What is the right diet for people? For some people, vegan works really well. You know, I have patients that are not vegan, but have very good other aspects of their health, and their lipid profiles are great, and their risk has gone down, and they do exceptionally well. So, you know, does everybody need to be a vegan? Maybe not. Does it work for you and your lifestyle and your numbers when you get them assessed, your lipid profile, maybe ApoB, um, uh, high sensitivity C-reactive protein, which is a marker of generalized inflammation. And if you don't have some inflammatory disease or a badly sprained ankle or the flu, when you get it checked, it's a surrogate for active inflammation in your coronary arteries. If it's elevated, it should be addressed. You know, if people can have beautiful numbers even if they eat animal-based protein. And so, you know, if you look at blue zones, we're talking longevity, and not just lifespan, but health spans, another term from Peter Attia. Are you healthy? Are you active? Are you enjoying life? or you loaded down with medications and you're inactive and on an oxygen tank in a wheelchair. So you can live a long time, but are you healthy a long time? If you look at the blue zone areas that Dan Buettner looked at as well, the Adventists in Loma Linda, largely vegetarian, if not vegan, but the other areas in Okinawa, in Sardinia, and Costa Rica, none of those areas were even vegetarian. They all have smaller meals. Calorie restriction is associated with longevity. And some people take it to extreme, and they do with a long-term water-only fasting, or they go on the one meal, the OMAD, 1 meal a day, OMAD, the OMAD diet, etc. But calorically less, very active. These societies would grow their own food, buy things fresh, etc. So I don't know. I don't push being completely plant-based on my patients in the office. I think, like I tell them, you can never eat too many vegetables. And I think the vast majority of my patients really don't eat that much vegetable matter.
Yeah.
So that, I'm not saying you could never have a steak again, but how about you have lentils and you have other legumes and soybeans and just have lots and lots of vegetables? Like the steak you're about to eat, what did the cow eat to make that? It ate grass. There's plenty of protein there, and that's what you can do. So, I don't club people over the head with being vegetarian or vegan when they first come to the office, for sure. But I do push making good decisions, eating less, and certainly having a lot more plant matter in your diet.
You talked about walking uphill.
Yes.
So is that the number one exercise you recommend? And here's the funny thing. When I'm at the gym, I usually do bike because I have bad knees, so I can't do too much running on the treadmill. But the best looking people are walking uphill, incline treadmill at the gym. So they must know something.
So I push walking because for most people it's easily accessible, it's cheap, it's always available. Now, Southern California in the summertime, a couple weeks ago, it's 112 degrees. Either you got to wake up really early or go after dark, and there are challenges with that. But I push walking because of its accessibility. If patients really want growth and improvement, they can't just, I've had patients that come and say, "Oh, I walk my dog." It's like, well, how much is the dog sniffing and peeing? Like, quite a bit. It's like, so you're not, so you, fine, walk the dog, drop the dog off at home, and then you go for your own 30-minute walk as briskly as you can without stopping. And so that's why I push walking a lot. Uphill to actually get the cardiovascular workout load. When I jog along Victoria Avenue in Riverside, there's not a lot of elevation change, but I know when I'm going uphill and I'm going downhill. It doesn't take that much, and you can feel the workload increase. There has been research done in psychiatry and psychological fields that show that people's sense of well-being is improved with exercise, but notably improved when people take a walk and there's trees around. I've actually studied this. Treadmill, city, or out in nature where there's trees, and the sense of well-being that comes along with exercise is improved when people are out in nature walking. So I really advocate walking. Also, it's weight-bearing exercise, good for your bones. So, I mean, there's people certainly with knee, hip, back issues that walking is difficult. And for those, I say you have to figure out something that orthopedically you can deal with, but then make sure you work hard. Don't just go to the gym and sit on a recumbent bike and sort of pedal with no resistance. You got to break a sweat. But that's why I push walking, because it's accessibility.
Do you recommend usually?
The American Heart Association guidelines are 150 minutes of moderate intensity exercise per week, which way they would describe as a brisk walk.
What if you do that once a week? You get it all done.
It seems not to matter how you break it up.
Really? Wow.
So if you were very consistent and regimented and went to the gym and did 30 minutes on the treadmill 5 days a week, or you're a weekend warrior and you took 1 or 2 long walks that added up to that 2.5 hours, probably doesn't make that much of a difference from a biochemical standpoint. If people really want to make improvements metabolically, they actually should be aiming for more like 4 to 5 hours per week. And then if they can add some type of strength training in, an additional hour per week. Because we all, we peak our testosterone in our late 20s. It starts to drop off. Women as well. We lose muscle mass. That changes just how we process energy all the rest of the time when we're not in the gym or exercising.
Yeah.
And so to maintain muscle mass is very important as well for metabolic health. But I love hiking.
Nice.
And walking. So that's my and I'd look at people's addresses and I recommend, you live somewhere in Riverside, you need to go to Mount Rubidoux. City set that as a park. You can go up the easy way, you can go up the steeper hard way, and go to Idlewild, go to Big Bear. So people I think they appreciate that I actually look where they live and give them options. Live down in Murrieta, you need to go to the Santa Rosa Ecological Plateau.
Nice. It's practical solution.
Yeah.
I want to go back to cholesterol. So what is the bad guy here? Is it cholesterol or actually
LDL
or high triglycerides?
So triglycerides tend to go up with insulin resistance. And, we see uncontrolled diabetics sometimes with triglycerides, hundreds and hundreds, maybe thousands high. Not a good situation. So as your triglycerides go up, especially if it's in conjunction with, if you get your hemoglobin A1C measured as well, and that starts to go up, that's a sign that you're metabolically not as healthy as you should be. In my day-to-day office practice, when I see patients, I focus mostly on the LDL. I see the triglycerides, I see that total to HDL ratio. Those are the basic markers I can find out if someone's being metabolically healthy or not. If I see that ratio come down, that's my favorite thing to see with my patients. That means their overall cholesterol is coming down and their good cholesterol is probably being driven up by active exercise. So we don't really have medical therapy that will raise HDL. I mean, there's a couple things that can do it, but they've never been shown to lower risk of heart attacks. We can give people huge doses of niacin or fibrate medication, raise the HDL, but it doesn't improve them. If they start to exercise more and they inch their HDL up 5 points, but with all that exercise, they get some weight loss and their total comes down and that ratio improves, then I know that they're metabolically headed the right way. So I don't focus on triglycerides that much. I do address it with my patients. I tell them it can be a marker of whether they're metabolically healthy or not. And the less metabolically healthy, the more we worry about active inflammation inside the coronary arteries, leading to cholesterol deposition and making the risk of rupture of that cholesterol plaque and a heart attack higher. But we focus a lot more on LDL, which then the natural segue is, well, that LDL, what about it? And the natural segue is to statin medication. And there's all kinds of stuff that's available all over the internet. Patients come and tell me they read this, they read that, it's bad.
It's the studies question we actually had for you.
Right, that's why I'm getting to it now. Statin medications,
Alzheimer's.
No. The studies that look, do they cause cognitive decline, have never statistically shown that they cause any cognitive decline that's measurable. That being said, I've had the occasional patient who tells me they have some brain fog and they're kind of fuzzy when they started taking their statin therapy. And this is after a heart attack. And we talk about it. And I say, look, overall, the studies don't show, but there's individual differences. People have idiosyncratic reactions. I want you to take it because I know it lowers your risk of having a heart attack. Behind aspirin is probably the biggest bang for the buck at lowering the risk of a future heart attack. But stop it. And And if the symptoms you complain about markedly improve, I will document my note that we had this shared risk conversation and we'll take you off the statin. But by and large, I don't have patients complain about it. That's probably less than 10 patients in 10 years that really felt like they had true brain fog. I have people ask about it, but I have very, very, very few patients that ever really told me they had any feeling that they had any cognitive issue with it.
It's more muscle cramps, I think.
A lot of people tell me that they have muscle aches on the statins and want to get off of them. And they have different water solubility levels. And so it's actually pretty surprising if you go 2 or 3 trials of different statins that you can actually find one that people tolerate okay. It's not a full class effect. If people are willing to give it a trial with an open mind, we can usually find one that they tolerate from a muscle achiness standpoint. And the actual rhabdomyolysis, which is breakdown of the muscle tissue, that's exceptionally rare.
Do you actually keep the patients on statins for like long term, or
Yes.
You cannot fix it with like diet and lifestyle exercise?
If I had a patient, and this would be very exceptional, but if I did, that made enormous lifestyle changes and had every single marker improve, I would still probably recommend they stay on a statin, but I would lower it. So the American Heart Association a few years ago went away a little bit from looking at the number of the LDL to let's get everybody who's had a heart attack on high intensity statin therapy, which would be like Lipitor, atorvastatin, 40 or 80 milligrams, rosuvastatin, 20 milligrams. If someone really makes improvements in their lifestyle, they're exercising, they're eating really well, making good diet choices, along with that comes improved muscle mass, decreased weight, decreased insulin sensitivity, etc., I'll back off on their statin. I won't go you can individualize it to the patient. But the LDL, I think, is most useful as a marker. And I tell that to my patients, say, look, we test your blood. We see a certain level of your bad cholesterol, LDL. If it's really high, epidemiologic studies show that 10,000 of you, if it's really high, would be at higher risk of someone than 10,000 with low LDL. So it's a marker for something else. It's also in treatment a marker that if we give someone a statin, we watch their LDL go down. Is it really lower circulating levels of LDL? And it's not. The statin medications really get their or derive their benefit from what they do in the blood vessels and in the cholesterol plaque itself. And they improve the health of the endothelium, the inside lining of the blood vessel. They make it thicker, secreting and producing a lot more nitric oxide, much less likely to ever break down and ulcerate over a cholesterol plaque and allow a heart attack to happen. Cholesterol plaques, back to the chemistry side of it, you can have material that's either in an oxidized state or reduced state. The more oxidized the plaque is, the more inflamed that plaque is. People talk about these foamy macrophages, these cells that go in and they're sort of eating cholesterol profiles and they're big and they're inflamed. Or you can have plaque that's very hard and firm and from an inflammation standpoint, very quiet and very, very unlikely to ever rupture and cause a heart attack. Statin medications have been shown in basic science studies to achieve those two goals: improve endothelial health, stabilize plaque, and that's how they get their risk reduction for future heart attack and the longevity benefit. It's unequivocal. Now, improving your diet and eating lots of colorful plants full of antioxidants will do the same thing. To the same degree, no, I don't think it replaces. I think if you've had a heart attack and your risk is that high, you should be on a statin lifetime. Exercise, same thing, improves endothelial health, stabilizes that cholesterol plaque. And I really try and push the two things together. I think if you bring them both together and don't go all one way. Here, just take these pills and you'll be fine. And I'm not going to bother to talk to my patients about lifestyle. I think that's horrible medicine. If you go completely homeopathically, I think you're missing out on some true advances in medical science. So you have to marry the two. And LDL is best as a marker. It's not the end all be all. It shouldn't be labeled bad cholesterol, good cholesterol. It's a marker assessed within someone's overall cardiovascular risk and their health status.
What about omega-3 index?
You know, there's again these lifestyle epidemiologic studies that looked at countries that eat lots of cold water fish, the Norwegians and the Japanese primarily, lower cardiovascular event risk overall than countries like the United States that don't eat a huge amount of cold water fish in their diet. They try and control for other statistical anomalies. I think there's something else about maybe being Norwegian and Japanese and being there that helps in addition to the cold water fish. So I don't think there's ever been any evidence that if you take an omega-3, whether it's krill oil or the different ratios, omega, the 6s and the 3, that it's really preventative. Eat your cold water fish and be like the Japanese. They eat small amounts. They have a lot of root vegetables. There's a lot of talk about fermented foods and biome being really good. That's a whole other discussion. The Norwegians are out there cross-country skiing and splitting wood, and they have, sit in front of the fire in the long winter months and having your family around. Do those things in your life. Don't just take some fish oil capsules you buy. They are beneficial if people have high triglycerides and you actually take omega-3s, it can bring it down. That's a fairly natural way. You can do it with flax oil as well to get your omega-3s.
Do you have any vitamin suggestions for your patients?
No,
their heart health?
No, I don't. Nothing really specifically. For people who have, people will tell me they have maybe muscle cramps in the middle of the night, or a lot of patients who come in with these sort of non-specific rhythm issues. They feel palpitations, skip beats, which a lot of times are just an early heartbeat, a little bit of a pause, and then a stronger follow-up heartbeat. People feel like they skip and they palpitate. I very routinely recommend magnesium.
Okay.
And magnesium glycinate, which is a rather new form. I think it's really, you want to get the magnesium in. If you get the wrong magnesium, it's just a pure laxative, like magnesium sulfate that will race through you and you will get. But magnesium oxide used to be easily available. Magnesium chloride, Slomag. But magnesium glycinate is glycinate I see a lot more now. And I've had my patients tell me no issues with loose stools with it. It's absorbed very well.
I'm glad you mentioned that, because especially when I was pregnant, I think once or twice my heart would just have like a beat, and then beat, and then I'm like, what is this? What's going on?
So there are all kinds of different environmental factors, including a gravid uterus pushing up and changing everything in between, maybe leading to acid reflux. GERD can do it. Caffeine, alcohol, lack of sleep, that wind up changing probably stress hormone levels a little bit in the body, which can then lead to a little bit of increased irritability from an electrical standpoint of the cell membrane of heart muscle cells. And all that can lead to any heart muscle cell could initiate a heartbeat. Usually it's just our cluster called the sinus node or SA node that does it before anything else. But if something's sort of tickling some area of the heart muscle and decides to fire off early, people get these palpitations, skips, a few fast in a row. Sometimes there's like a little gap and they feel a weird feeling. It's a very common consult I get. We monitor patients. A lot of times we can say, look, you're just feeling these early beats. They're very benign, nothing to worry about. And then I'll say, listen, I could prescribe you a medication, a blood pressure medicines that you could take that might suppress it if you really wanted to, if the symptoms were that bad. Or you could try a little magnesium and just live with it because it's completely harmless. Almost invariably, people will turn me down for the prescription, which is good. I do it for a living, but I think less is more. They try the magnesium. Once they're reassured, okay, that's what I feel, nothing harmful. All right, I can live with it.
So magnesium glycinate.
That
would be.
Yeah, probably over the last year and a half, patients have come to me and told me that's what they've started to take, and they absorb it really well. Better than the old, Magox, magnesium oxide is still fine. Magnesium chloride's fine. Those are a little more variable absorption. They still, they're still fine. But glycinate's getting cheaper, and that's the one I recommend to patients now. Beyond that, I really push patients, look, get all of your vitamins from the produce section. That's where you have them all. People sometimes have issues with B12 absorption as they get older, and they need B12 oral supplements, or if it gets really bad reabsorption, they need to get injections. Sometimes iron a little bit sketchy absorbed as they get older. But by and large, there haven't really been any supplements that have really shown. CoQ10 can help some people who have achiness in their muscles with statin therapy. That's been studied clinically, and it shows that there's improvement. But short of that, there's no real role for CoQ10. I have patients asking me fairly recently about beetroot extract because it gets advertised as a really strong antioxidant, and I tell them, you could do that, or you could eat the beets.
Yeah.
I can't stand beets, so I'd never get it. So if I really wanted that particular group of antioxidants in that really deep red of a beet, I would probably have to take the capsule because beets are the one vegetable I can't stand.
We should got that for the girls and for us.
Yeah, so if I tell patients, if it's not a financial burden to you at all, and you want to take a supplement like that, it's fine. But get the fiber with it. You get water when you get your vegetables and fruit as well to replenish the water in your body, in addition to drinking water. So the more you can get straight from the plant as God made it, as natural, unprocessed, I think that's better. But there's certainly nothing wrong with doing that with the beetroot.
We know you're busy, and we really appreciate you coming in. But for if you don't mind, what do you do personally? What do you like? What type of diet do you eat, and what type of exercise regimen do you follow? And
sure. So
we asked the cardiologist.
Yeah,
what he does.
I'm not vegan. I'm not vegetarian. I do eat some meat.
Okay.
Occasionally, we don't eat at home because my wife and daughters are vegetarian. But a few times a year, I will go to In-N-Out. And yeah,
we don't judge.
But what do? I think a little intermittent fasting is a good thing. I can't remember if this is one of Peter Attia's online lectures in his book. But think about my grandfather, who was a dairy farmer in Maine, and in the winter would also do logging. And they were up to milk the cows 4 a.m, and he didn't have breakfast. He would work for 3 hours and then come in and have breakfast. And from our hunter and gatherer ancestors, you didn't start out with a big breakfast. You went out and found breakfast.
Yeah.
And so I have started, I don't eat before I go to work. I have coffee with a little bit of half and half in it, but no sugar, no sweeteners. And a big, first thing I do when I wake up is lots of water. Tom Brady does that, my favorite athlete. Lots of water. Coffee with a little bit of half and half. And then somewhere around 11 o'clock, usually some nuts. Walnuts are probably the most heart healthy nuts. So walnuts, almonds, pecans, and fruit, fresh fruit. For lunch, I typically have a fairly big Tupperware. It's not really Tupperware, but in the 1970s, as I was growing up, all the women had Tupperware parties. I have a container of usually fresh vegetables, bell peppers, celery, broccoli, carrots, raw. I'm too lazy to get a little thing of hummus. My wife, Krista, will do it, but she's got to have the hummus, but she doesn't like this straight raw. But I'll just eat a big container of raw vegetables, and then sort of whatever we had left over from the night before, a little bit, if there's some leftovers.
So like a late breakfast and a lunch?
Yep.
Followed by lunch, or?
Followed by lunch. Not that
immediately,
not that long.
Like
just about an hour and a half in between, like 11 o'clock. And then somewhere around 12:30 when I'm just typing during the regular lunch hour, typing up all my notes, etc., then I'll go ahead and eat lunch at the same time. I do eat too late at night.
Okay. How late?
Teenage girls, busy running around doing stuff, get home late from work, and so we wind up eating almost very routinely after 8, sometimes 8:30 to 9, which is really too late. I wish we ate earlier to give a little bit longer fasting period from when I was longer time between my last meal and bedtime. So that's one of the biggest things I would change with my diet, and cut back on my sweet tooth because I do like my sweets. But yeah, so I wait to eat nuts and fruit, lots of raw vegetables at lunch. Try and eat a sensible sized dinner as early as we can. Exercise, I either go jogging if the weather's not too hot. I'd like to jog outside. We live not too far from Victoria Avenue, a couple blocks off Victoria Avenue in Riverside, and it's got a jogging path, and it's just a great place to jog. Other people are out. It's very enjoyable. Nice. A little bit of social interaction too, and I see a few same people sometimes. We do have a treadmill down in our basement rec room, and we put a lot of miles on that between my wife and myself, either jogging on it, or I set it at about 3.5 miles an hour with an incline of 12 to 14. So walking uphill on it. I go to church on Saturday mornings, and that's when I do my longest jog. I will jog between 45 minutes and an hour. Fairly slow, but do a long jog on Saturday mornings. And then I try and exercise. I try and get 3 other times during the week. Often winds up only being 2. And then sometimes soccer on Sunday afternoons with the Sam and my daughter. Yeah.
Awesome. Yeah. Well, we'd love to have you again, if time permits. There's so much we could ask and talk about, but we really thank you for giving your time and knowledge and expertise.
Sure.
Sharing with us.
Eat vegetables and walk uphill. It's my mantra.
Awesome. And no smoking.
Thanks. No, absolutely not. Absolutely not. That's the worst thing you could do. And yeah, I'd always tell patients, it's in your hands. You quit, you'll do more for you than I can do for you.
Yeah. Amazing. Yeah. Thank you for your time.
Thank you so much, Doctor.